It's really an honor to be here with all of you. I've heard quite a bit about you all from Mary, and I just also want to say thank you for the support that you are providing to this department. It has been honestly sort of a dream come true, finally joining Columbia. I've known Mary for years, and I'm just thrilled to now be part of her team and to have her as a mentor. So as Mary mentioned, I've been working at the Department of Health since 2017, where I've been working reviewing cases of maternal death in this city. And what I'm going to do today, this afternoon, is just share some of the key findings and recommendations that have come out of that work. Okay, so I'm just going to advance here. So there's a lot of data, of course, lots of numbers, and I feel like we can often get lost in that. And to ground us this afternoon in this discussion, I thought, let me start with some pictures. They're a little hard to forget the real stories of these women. It's harder to sort of gloss over compared to just the numbers in the charts. So this here is a picture of Erica Garner. And that's Eric Garner there at the bottom right, her father. And for those who are unaware, Erica actually died after giving birth to her son. And I reviewed hundreds of cases, as I mentioned, of maternal death in this city. And the reason I chose to highlight Erica's case is because this was a situation of a young woman who was marching in the streets of this city, demanding justice for her father's wrongful death. I know we're all aware of what happened, so I'm not going to go into those details. What was just very difficult for me is that she then herself died weeks after giving birth to her baby. And this family's tragedies were just so poignant of the crossroads of racial inequity that we're out in this country. And I just felt that, look at this family, they are being assaulted on every side. And it was absolutely heartbreaking to me that healthcare happened to be one of them. So as I described today, some of the work from our committee and the recommendations that have come out of the committee, I think you're going to agree with me that we, and when I say we, I'm talking about the collective we, the healthcare establishment, all of us, we really can do better, and we have to do better. So who are we at the City Department of Health, and what is it that we're doing? So we're a group of about 40 people. We're made up of community activists, doulas, midwives, nurses, maternal fetal medicine specialists, OBGYNs, anesthesiologists, cardiologists, oncologists. We also have case managers and public health workers, police and first responders. We have medical examiners, social workers, and reproductive justice advocates. It's a large group. Half of us identify as Black or African American, and 15% identify as Hispanic. And the reason that I point this out is because, these are the two main groups that are affected by this maternal death crisis. And I'm pointing it out also because part of what we do in this committee is we're reviewing all available records. We look at medical records, we do internet searches, we create this detailed narrative, a story of what happens to each woman. And we then present it in front of the whole committee, and we talk about it and try to come up with recommendations to try to prevent things, similar things from happening to other women in the future. And so in an effort to truly understand what happened to these women, what their lived experiences are, it's very important that we have the right racial and ethnic makeup representation in our committee as well. And we also pride ourselves in that about a third of our members are actually community representatives. The rest are clinical. We've got lots of doctors, as you can see, but about a third of us are actually from the community. And as you'll see, understanding the community, partnering with leaders in the community, all of these things are really important in being able to advance the health of communities. So this is another very important part of who we are. So what do the numbers actually show? In this slide, you can see the average Black-white disparity. And this, again, is the pregnancy-related deaths in our city. And this is since 2001. And you'll see that the ratio for Black mothers, for the death of Black mothers compared to white mothers, has ranged anywhere from 6 all the way up to 17 times higher for certain time periods. As for that same measure in white women. On average, it's about 9.4 times higher for Black women versus white women over this time period. Now, in the past, as you know, we used to think that this was race, and we thought it was due to this biologically based thing that had to do with race. But we now know that that's not what's going on. It's the greatest driving force behind these inequities in maternal deaths is not race. It's the differential access that these women have to power and resources. It's things such as income, access to generational wealth. This is what makes a difference. What's the access to food like in a neighborhood? How easy is it to access good health care? Parks, public spaces, all of these things actually make a difference in somebody's health and their ultimate health outcomes. And at the same time, disproportionate overexposure to other things. Mary was talking about the environment. We know that certain environmental toxins are really harmful, and certain neighborhoods have higher amounts of these things. Disproportionate over policing, incarceration, all of this contributes to what we call the social determinants of a person's health, which is what we're going to talk about a bit more later this afternoon. Now, this slide I really like because it shows the racial disparity in a slightly different light. This is New York State data for 2018, and you can see here the pregnancy-related deaths and the live births by race and ethnicity for that year. And what you can see here is the data for Black non-Hispanic women. The death rate is in the solid blue, and then the hashed blue bar is the live birth rate. And what we see is that in these women, they're overrepresented in the pregnancy-related death cohort, because you can see that only 14.3% of live births in New York State are actually to Black women, Black non-Hispanic women, whereas 51.2% of these women make up the death cohort. And this is in stark contrast to white women. White non-Hispanic women are giving birth to 48.2% of the live births in this state, and they make up only 34.1% of the death cohort. And this again is state level data, but we see the exact same thing in the city. And we're seeing in the city that Black moms are giving birth to about 1/5 of the live births, and they account for over half of the deaths in the city. The other interesting information that I wanted to share with you guys this afternoon is that the majority of women are actually dying after they leave the hospital. They're dying in the weeks to months after they leave the hospital. And they're dying most often from things like mental health conditions, cancer, cardiovascular conditions. This is happening back home in the community. And so our reviews of these cases, there's a very clear argument that can be made for improving partnerships within the community. We need more programs, home visiting programs. We need better coordination with community-based organizations that can provide assessment, referrals to help us access these women and get them in for mental health services, drug treatment programs. You know, we know that we have to do this work. The data shows us, but the work is really, really hard. And it's not as clear and as easy as just ordering some medicine or just performing a surgery on a patient. It requires that hospitals like ours partner with their local community. We have to really understand what are the challenges, what are the needs, and then we have to partner with our community in really honest, sustainable, and meaningful ways. And all of these things are hard and they take time and a lot of energy. It's important because in the end, healthcare systems play a really, really important role in the equity equation. Everyone's talking about being equitable, providing health equity, but how do you do that? You know, it's really hard, of course, it's complicated, there's no easy answer, but it definitely starts by understanding and recognizing that not everybody is going to benefit from the same support as this illustrates here on this side. The support has to be the kind of support that the people or the community really specifically needs. And you have to look at who are they, what are their life challenges, where do they live, what do they have access to, what do they not have access to. It's not just about the quality of the healthcare inside of the clinic or the hospital, right? It is about understanding and addressing those social determinants of a person's health that affects them well before they walk into your office or into your hospital. So here is just another slide to point out understanding how important it is to understand the social determinants of a woman's health or a patient's health. And what this is illustrating is that about 80% of health outcomes are actually being driven by what we collectively refer to as social determinants of health, which is what's outlined there in that yellow box. So the question then is, what can we do and what should we do? What must we do? And it really starts with just having the healthcare system collectively. We need to acknowledge that race, institutionalized racism, other forms of discrimination, all of this also serves as social determinants of health, and understanding that health systems promote health equity when their design and management specifically considers the circumstances and the needs of socially disadvantaged and marginalized vulnerable populations. This is really where it has to begin. And then we can move to, what do we actually do? We have to inquire about and document social and structural determinants of health for every single patient. We have to partner with the local community to understand what the cultural barriers are. We can't assume that we know, right? We have to talk and have meetings and listen. We have to understand what really are the obstacles to care and what are the unique challenges that these women are facing. And then we maximize referrals to resources. We partner with places that can provide these resources and social services. And we provide support in navigating systems and removing obstacles in the way for people to achieve their optimal health. So that's all that I have to share with you. And I am going to now hand it over to Dr. Cepin to talk specifically about the programs that she's been working on for our department in the community.
Thank you, Lisa. I'm going to wait and see whether or not I have control of the slides.
Alana is getting her slides up. I just thought I'd say, just as a point of reference, it is extremely rare that a maternal death occurs in our healthcare system. So it's very rare. But with that, we have to be leaders in the community and helping other hospitals. The other thing that although we don't see deaths very often, or it's very rare, we do see morbidity, near misses, women who nearly die. So we can also use all of those lessons that you heard from Lisa there to reduce the morbidity or the life-threatening effects that don't cause death. Sorry, Anna, I just thought I'd say that while you were joining, because those numbers look scary, and I just want to assure you they're rarely happening at our institution.
So I am also very happy to have the opportunity to speak with you today. And before I go into my talk, I wanted to share a story from last week. So I went to a photo exhibit that was sponsored by the Columbia Trust Project. It featured community health workers who worked during the who worked at the front lines during the COVID crisis. Community health workers are members of our community who are especially trained to serve as a liaison between patient and the medical system. During the presentation, there were two comments that I found especially meaningful for our discussion today about social determinants of health and community engagement. So when we became the epicenter of the pandemic early on, the governor was running around trying to secure warships and ventilators for the city. A community health worker spoke up and said that what we needed to focus on instead was helping our communities to isolate. So many lived in crowded, multi-generational homes where it is impossible to isolate, and this was leading to rampant spread within homes and families. Insight into our communities and recognition of this basic fact early on could have helped to stop infections and save lives. The other was about vaccines. So many healthcare providers were shocked when many of their patients did not trust their recommendation to get vaccinated. We learned the hard way that we had a lot of work to do to build trust between our communities and the medical system. So for some background, what is our community? Although our department takes care of women from the tri-state area and beyond, our home is Northern Manhattan. Washington Heights and Inwood is 72% Latino. Almost half were born outside of the United States, and 40% have limited English proficiency. 20% of residents live in poverty. Most are from the Dominican Republic, and in fact, this is the largest population of Dominicans outside of the Dominican Republic. Even Google Maps has called the area Little Dominican Republic. A little further south is Harlem, which is made up of Black and other Latino populations with a slightly different demographic profile. We are also increasingly seeing more patients from the Bronx as gentrification and rising rents has pushed long-term residents further away. These are incredibly vibrant, culturally rich, resilient communities. However, due to many systemic issues, they are also negatively impacted by social determinants of health, such as housing instability, food insecurity, immigration challenges, language barriers, and racism. And we know from Dr. Nathan's talk that it is incredibly important for us to address these issues to help prevent poor health outcomes. So what are we doing? New York Presbyterian periodically conducts a community health needs assessment. This needs assessment takes input from the community and stakeholders. And then it's all brought together and a determination is made as to what the areas of focus should be. In the most recent assessment, maternal and child health was identified as a priority area of focus. Our department then partnered with New York Presbyterian and took the opportunity to support me to develop a community women's health program. The goal was to set a vision and strategy for how we can best serve the women of our community. The guiding principles are to provide excellent care through a health justice lens, improve health outcomes, and also provide community service, engage with the community, and partner with the community. The first main project was the creation of a maternal and child integrated mental health program. This program allowed the alignment of 3 service lines. So obstetrics, pediatrics, and behavioral health came together to form an interdisciplinary team that then provides care to the mother-child dyad. One of the major goals is to counteract the toxic stress that many of our families experience that can have long-standing effects on health. We strongly believe that this 2-generational approach will let us address social determinants of health and allow our families to thrive. This is the portfolio of programs that are under the umbrella of MAC IMP. Healthy Steps, for example, is a parenting program. We heard about community health workers. These community health workers assist patients with navigation and access to resources. Postpartum doulas provide support during that critical postpartum period. These are all programs that have been very well received and that we already know are having a very positive impact on our patients' lives. I'd like to briefly share a narrative from a patient who participated in the doula program recently. She said, "I later realized by the end of our sessions that there was no way my son was going to be okay if I wasn't okay. And working with her was definitely the primary reason I got back to a state of being okay. She listened, she made suggestions, she really made me see that I was doing the best I could. I am a better mother because of the time spent weekly with my doula. This program is literally a lifesaver." Another major focus of my work has been engagement with the local community-based organizations. And so community-based organizations are trusted voices in the community and are truly our partners in helping to support our patients. This slide shows the community-based organizations that we have worked most closely with. We've collaborated on multiple programs, health education sessions, research grant applications, and even presentations to our department. We've also had the opportunity to focus on outreach to community healthcare providers. So, we're not the only healthcare providers. There are other practices in our community. And so these are unaffiliated practices that provide prenatal care, but many of their patients choose to come deliver with us. We've worked really hard to improve and formalize our relationships so that there can be better communication about patients that we share. Lastly, a major focus has been messaging. So I truly believe that this is key. It's very important to go beyond our walls and get important health information to our community members. So I've had the opportunity to participate in public health campaigns, Spanish language media, podcasts, and even hip hop videos. And then I'd like to finish up on this slide. Some may remember from the last time I met with you that my mother is a longtime Washington Heights community activist and inspiration to my work. Here we are in the Uptown for Choice March last month. And then a few weeks later, she received an award at a Dominican Mother's Day celebration. After thanking everyone, she strongly reminded everyone in attendance about how we really need to continue taking to the streets and not be complacent about all the work that remains to be done in our community. So I'm incredibly grateful to Mary and our department that we've been able to devote efforts to help the women of this community build their trust and improve their health outcomes. Thank you for the opportunity to allow me to speak today.